Hi everyone, my name is Jessica Harwood and I decided to do my project on neuroblastoma. As I did my research on neuroblastoma, I was especially interested in how much I learned about the cancer. I honestly hadn't heard very much about it. Cancer in itself is a very unknown and complicated disease, but neuroblastoma happens to be a very rare type of cancer that kind of caught my eye. So, let's get started. So I figured I would get started with a description of what neuroblastoma was. Um, Neuroblastoma is a cancer that is developed from immature nerve cells found in several areas of the body. It most commonly arises in and around the adrenal glands, which is in the abdomen, which also have similar origins to nerve cells and sit at the top of the kidneys. Um, Although it normally forms in the adrenal glands, it can also form in a patient's neck, chest, um, abdomen, and spine where nerve cells exist. I plan to break it down even further on the following slides. This image here just shows you where the adrenal glands sit on the kidneys in the abdomen. So, as I believe I said on the previous slide, most neuroblastomas are diagnosed in the abdomen and associated with the adrenal glands or sympathetic ganglia. Based on these common sites of primary disease and the cellular and neurochemical features of neuroblastoma, it's widely accepted that the cell origin for neuroblastoma arises in the sympathoadrenal lineage of the neural crest during development, as seen in this figure from NCBI. As cells of the neural crest migrate, they undergo EMT. A subset of cells migrate toward the dorsal aorta and they commit to the sympathoadrenal lineage. This migration is directed in part by the expression of the chemokine receptor CXCR4 on the migrating neural crest progenitor cells and the expression of the SDF1 chemoattractant on the dorsal aorta. At the dorsal aorta, the migrating neural crest progenitor cells committed to the sympathoadrenal lineage initiate their differentiation program in response to BMP signaling emanating from the dorsal aorta 199 to 200. A series of transcription factors, including PHOX2AB, ASCL1, GATA23, SOX411, INSM1, and HAND2 are upregulated. Shortly after these transcription factors are induced, neuronal markers are upregulated along with the genes that encode enzymes required, um, required for this. So there are different cell types that we deal with when talking about neuroblastoma. So the neural crest, as I tried to explain in the earlier slide, is a remarkable structure that's present only during embryogenesis and gives rise to diverse cell types, which include the peripheral neurons, the enteric neurons and glia, melanocytes, Schwann cells, and cells of the craniofacial skeleton and adrenal medulla. Basically, cells that arise in the adrenal medulla are postganglionic neurons that have lost their dendrites and axons. preganglionic neurons from the central nervous system connect directly to the adrenal medulla and stimulate the release of epinephrine, norepinephrine, and dopamine. So, with that being said, the adrenal medulla is a ganglion of the sympathetic nervous system. This slide is actually pretty interesting to me as it goes through kind of the commonalities of where neuroblastoma arises. Um, Most neuroblastoma, as we know it, arises in the adrenal medulla, which makes up about 65% of all neuroblastomas, and also making it the most common. Um, the rest is distributed among the chest at 20%, the neck and pelvis at 5%. Um, a pattern similar to that of the normal sympathetic ganglia in the thoracic and lumbar is 16%. And then we have the sacral that sits at 4% and the cervical that sits at 3%. Um, Also, a small subset of patients present with bilateral adrenal neuroblastoma, suggesting that the transformation can be initiated in the neural crust before the cells migrate. Alternatively, it's possible that patients with bilateral neuroblastoma had a predisposing genetic lesion, and the bilateral tumors result from two independent genetic lesions in the cells of the left and right sympathoadrenal lineage. So, when we talk about the symptoms of neuroblastoma, um, it differentiates a lot from other cancers. As we know, signs and symptoms of neuroblastoma are going to vary depending on which part of the body is being affected. Um, Typical neuroblastoma of the abdomen um, cause signs and symptoms such as abdominal pain, a non tender mass underneath the skin, um, distended abdomen, or problems with feeling really full, changes in bowel habits, constipation, or diarrhea. Um, Neuroblastoma of the chest can cause some different symptoms, such as problems breathing, wheezing, or swallowing problems, chest pain. A common sign is changes to the eyes, including drooping eyelids and unequal pupil size. More commonly, the other signs and symptoms that tend to show up if the neuroblastoma is spreading can be proptosis, which is the eyelids protruding from the sockets, dark circles around the eyes, um, similar to bruises almost, back pain, fever, unexplained weight loss, high blood pressure causing irritability in children, tachycardia, reddening or flushed skin, diaphoresis, and bone pain. Um, of course, presenting signs and symptoms are highly variable and they depend on the site of the primary tumor as well as if the cancer has or has not become metastatic. Um, the disease is remarkable for its broad spectrum of clinical behavior and biological heterogeneity. Taking another look behind neuroblastoma, it was pretty interesting. The cause is still not really known. Researchers have found important differences between neuroblastoma cells and the neuroblasts, which are early forms of nerve cells from which they develop. They've also found differences between neuroblastomas that are likely to respond to treatment and those that have a poor prognosis or outlook. Um, the differences, also known as prognostic markers, are sometimes helpful in choosing the best treatment. So, as we know with other cancers, lifestyle related risk factors such as body weight, physical activity, diet, and tobacco all play a major role, especially in many of the adult cancers. But these factors actually take many years to influence your cancer risk. And they're not thought to play much of a role in childhood cancers, including neuroblastoma. So, some of the risk factors that we see in neuroblastoma are age, um, as it's most common in very young children, but it is still rare even in this age group, and it's very rare in people over the age of 10. Heredity is also seen as a risk factor. In about 1 to 2% of all neuroblastomas, children will inherit an increased risk of developing neuroblastoma from a parent. But most neuroblastomas do not seem to be inherited. Those children that are found with the familial form of neuroblastoma usually come from families with one or more members who have had neuroblastoma as infants. And the average age at diagnosis of familial cases is younger than the age for sporadic cases. Another common thing that happens in children with familial neuroblastoma is that they sometimes develop two or more of these cancers in different organs. For example, in both adrenal glands or in more than one sympathetic ganglion. And it can be really important to distinguish neuroblastomas that start in more than one organ from the neuroblastomas that have started in one organ and then spread to others. If the tumor has seemed to develop in several places at once, it suggests a familial form, which might mean that the family members should consider maybe a genetic counseling and testing. But both familial and neuroblastoma that is not inherited can spread to other organs as well. And then the last risk factor is birth defects. Some studies have shown that children with birth defects might have an increased risk of developing neuroblastoma. There's some link between birth defects and neuroblastoma that might be related to changes in the genes that happen during the fetal development. So, when talking about early detection in neuroblastoma, it's nearly impossible with childhood cancer that develops during development itself or in the early stages of life. Um, and random DNA mutations during fetal development, like the ones that scientists believe may be linked to the development of neuroblastoma, are random events. So, in most cases, there's not a specific cause or trigger. The scientists don't believe that these specific DNA mutations are caused by lifestyle or environmental factors, as they are with most adult cancers. Therefore, there's really no way to prevent these DNA changes or the development of neuroblastoma. In fact, at this time, there's really no way to prevent most forms of childhood cancers. As far as screening is concerned, researchers have studied whether screening infants for neuroblastoma might help them find these tumors earlier and lead to better treatment results. However, screening, like testing for the disease and cancer in people who don't have symptoms, haven't really shown to be helpful. The studies have found that neuroblastoma screening isn't the most helpful. Testing infants when they're 6 months old um, might find tumors that wouldn't have normally been diagnosed, but most of these tumors end up being a type that probably would have gone away or matured into benign tumors on their own. And these tumors probably would never have caused any problems to begin with. So ultimately, the screening didn't lower the number of cancers found at the advanced stages or save lives. There are the few rare instances, though, where neuroblastoma was found before birth during an ultrasound, um, which ultrasounds are usually done to estimate the age of a fetus, predict the due date, and look for any common birth defects. Although, with improvements in ultrasound technology and other tests, that may lead to more accurate prenatal testing for this disease. For the diagnosis of neuroblastoma, there are many tests and procedures that we follow. Um, First and foremost is the physical exam, where the doctor consults to check out any signs or symptoms and ask questions about your child's habits and behaviors. Um, and then, comes the urine and blood tests, which can indicate any cause and signs and symptoms that your child is experiencing. Um, the urine test can also be used to check for high levels of certain chemicals that may result from the neuroblastoma cells producing, these excess substances. We have imaging tests, which could reveal a mass that indicate a tumor. And some imaging tests may be an X-ray, ultrasound, CT scans, MIBG scans, and MRIs, among many others. And then, of course, you have the typical biopsies where if a mass is found, your child may remove a sample of the tissue for testing. And then specialized tests on the tissue sample itself can reveal what types of cells are involved in the tumor and specific genetic characteristics of the cancer cell. That could help your doctor devise an individual treatment plan. And then one of the last diagnosing factors is removing a sample of bone marrow for testing, which is also known as a biopsy. It's a biopsy of the bone marrow and a bone marrow aspiration to see if neuroblastoma has spread to the bone marrow, which is the spongy material inside the largest bones where blood cells are formed. In order to remove bone marrow for testing, a needle is inserted into your child's hip bone or lower back to draw out the marrow. So, this is typically something that we save, to do last. It's not a very comfortable procedure. Okay, so we'll talk a little bit about staging. Once neuroblastoma is diagnosed, your doctor will typically order further testing to determine the extent of the cancer and whether it has spread to distant organs, which is also, known as staging. And knowing the cancer stage helps the doctor decide which treatment is going to be the most appropriate. Tests that we're going to use to help us stage are going to be those imaging tests that I talked about on the previous slide. The stages of neuroblastoma are indicated by Roman numerals that range from 0 to 4, with the lowest stages indicating that cancer is limited to one area. By stage 4, the cancer is considered advanced or that it has spread to other areas of the body. For neuroblastoma in particular, several other factors are looked at, along with the child's stage to decide which risk group a child will fall into. A risk group is an overall picture of how a child's neuroblastoma will respond to treatment and helps doctors select the treatments that might work the best. Doctors also use neuroblastoma risk groups when talking about survival statistics. The two systems used for staging neuroblastoma today include the INRGSS, the International Neuroblastoma Risk Group Staging System, and the INSS, International Neuroblastoma Staging System. The main difference between the two systems is whether the staging system can be used to help determine a child's risk group before treatment has started. The INRGSS uses results from imaging tests to help decide a stage of diagnosis. It can be determined before treatment has even started. The INSS uses results from surgery to remove a child's tumor instead of imaging tests. Since many children with neuroblastoma have surgery as part of their treatment plan, the INSS does not work well for assigning a risk group before treatment has started. Um, INRGSS is now being used to determine staging for most children's oncology group studies. But some studies have results that will be published over the next few years that use INSS. And the staging systems alike can both be used to help make sure that children with neuroblastoma get the treatments that are best for them. So let's talk a little bit about treatment. Um, your doctor is going to select a treatment plan based on several factors that affect your child's prognosis. The factors include a child's age, the stage of cancer that they have, the type of cells involved in the cancer, and whether there are any abnormalities in the chromosomes and genes. And then your child's doctor will use this information to categorize the cancer as low risk, intermediate risk, or high risk. What treatment or combination of treatments that your child receives for neuroblastoma will depend on the risk category. So, surgery is the first treatment. Surgery is used to remove the cancer cells in children with low risk neuroblastoma to remove the tumor, and it may be the only treatment that is actually needed. Whether the tumor can be completely removed depends on its location and size. Tumors that are attached to many nearby organs, such as the lungs or the spinal cord, may be too risky. It's also used for those intermediate and high risk neuroblastomas because surgeons may have to remove as much of the tumor as possible. And other treatments, such as chemotherapy and radiation, may then be used to kill the remaining cancer cells left behind. The chemotherapy is used mainly for children with intermediate and high risk neuroblastomas. The intermediate risk neuroblastomas often receive a combination of chemo drugs before surgery to help improve the chances that the entire tumor may be removed. While children with high risk neuroblastoma usually receive high doses of chemotherapy to shrink the tumor and kill any cancer cells that have spread elsewhere in the body. The chemotherapy is usually used before surgery and before a bone marrow transplant. The radiation is for children with low risk or intermediate risk neuroblastoma. They may receive the radiation therapy if surgery and chemotherapy hasn't really been helpful. Children with high risk neuroblastoma may receive radiation therapy after chemotherapy and surgery, only to prevent the cancer from reoccurring. The bone marrow transplant is only going to be in children with high risk neuroblastoma. And they may receive a transplant using stem cells collected from bone marrow to replace their stem cells. Immunotherapy is another high risk neuroblastoma treatment. It uses drugs that work by signaling your body's immune system to help fight cancer cells. And children with high risk neuroblastoma may receive immunodrug therapies that stimulate the immune system to kill the neuroblastoma cells. As with any cancer treatment, we have these newer treatments that are coming into play and research that is being done on many different treatments. So doctors are studying a newer form of radiation therapy that may help control higher risk neuroblastoma. The treatment uses a radioactive form of the chemical MIBG. And when injected into the bloodstream, it travels to the neuroblastoma cells and releases the radiation. MIBG therapy is sometimes combined with chemotherapy or a bone marrow transplant. After receiving an injection of the radioactive MIBG, the child will have to stay in a specialized hospital room until the radiation is able to completely leave the body in their urine. And the MIBG therapy usually takes a few days. On this slide, I went ahead and found this chart um, that compares all of the childhood cancer diagnoses per year. So, looking at this chart, um, you basically see the number of childhood cancers diagnosed per year from ages 0 to 19. And this is totaling um, an amount of candidates that are totaling 15,270 children. Um, as you can compare, you see that there are many different children cancers that are higher, like leukemia, brain and central nervous system cancers, um, other unknown or uncategorized cancers. But neuroblastoma is pretty high up there for children, as it kind of falls in like that fourth place slot. So ultimately, it may not seem like it is a big cancer, but given the other cancers that children can be diagnosed with, it's pretty significant. Okay, so I also found this pie chart on childhood cancer rates by the American Childhood Cancer Association. And I like it because childhood cancer is a general term describing more than 12 different types of cancer, each of which has numerous subtypes and each of which requires precise treatments protocols tailored to the small, still developing bodies of children. The American Childhood Cancer Organization is dedicated to raising awareness about the unique challenges presented by childhood cancer and the desperate need for new and better treatment protocols that will target these dangerous cancers without the permanent and disabling late term effects that can be all too commonly resulting of childhood cancers with drugs developed to cure adult cancers. Um, as you can see on the chart, neuroblastoma is one of the lower cancers rated among children, which kind of, to me, makes it a little bit more interesting to do research on because you have all these more common cancers that we see in children, like leukemias and brain cancers and carcinomas and lymphomas. But then you have these lower rated cancers that aren't really focused on so much. Um, and it's just really, really interesting to see how the rates compared to other cancers alike for children, as in this chart and the previous chart from the previous slide. So after going through basically most of what's needed to know about neuroblastoma, let's talk a little bit about the prognosis. Um, Prognosis factors are certain markers that can indicate whether a specific neuroblastoma may respond better or worse to treatment, and it can impact a child's long term outlook. Specific prognosis factors used to help assign risk for neuroblastomas are age. Um, Children under 12 to 18 months tend to have a better long term outlook than older children. Um, the tumor histology, when examined under a microscope, tumors that contain more normal looking cells tend to have a better prognosis, which is basically coined as favorable histology versus unfavorable histology. The DNA ploidy, that's in young children. Neuroblastoma cells that contain the same amount of DNA as normal cells seem to respond less favorably to treatment than those who have an increased amount of DNA. The MYCN gene amplifications are neuroblastomas with too many copies of the MYCN oncogene, which is a gene that helps regulate cell growth and division, seem to grow more quickly and respond less well to treatment. Chromosomal changes also have a factor where scientists are just now beginning to understand how the presence or lack thereof of certain chromosomes with the DNA structure of the cells can impact the prognosis for neuroblastoma. And then we have the neurotrophin, which is the nerve growth cell factor receptors. Those neurotrophin is a chemical that helps nerve cells mature. In neuroblastomas that have more neurotrophin receptors, especially those receptors called TRKA, are associated with a better long-term outlook. So, continuing on with the prognosis, let's look at the 5-year survival rate by risk group. Those children whose neuroblastoma is considered low risk have a 5-year survival rate that is higher than 95%, which is pretty good. The intermediate risk are children whose neuroblastoma is considered intermediate, have a 5-year survival rate of 90 to 95, which it's still very, very good odds. And then it's really the high risk that seems to make quite a leap in how much it decreases from having a good survival rate to a not so good survival rate. So for children whose neuroblastoma is a high risk, they have a 5-year survival rate of 40 to 50%. This cuts the survival rate percentage in half from both the low risk and the intermediate risk patients. I added this slide in to talk about the neuroblastoma health disparities. In this chart here is a pretty good indicator of the estimated probability of event-free survival and the time diagnosed in years based off of the different ethnicities. So Black and Native American patients with neuroblastoma have a higher prevalence of high-risk disease, accounting for their worst EFS when compared with whites. The higher prevalence of late occurring events among Blacks with high-risk disease suggests that this population may be more resistant to chemotherapy. Studies focused on delineating the genetic basis for the racial disparities observed in this study are planned. So, in a study that I read from the University of Chicago Medicine, Black, Asian, and Native American children are more likely than white and Hispanic children to die after being treated for neuroblastoma, according to some new research on pediatric cancer. The study of more than 3,500 patients with the disease was the largest ever to look at racial disparities in risk and survival for the most common solid cancer found in young children. The study also went on to find that Black and Native American children are more likely to have the high-risk form of the disease and show signs of resistance to modern treatment. Those biological characteristics suggest that genetic factors contribute to the outcome of disparities found for neuroblastoma. In this subject pool of 3,500 children diagnosed between 2001 and 2009, it enabled a research group led by Cohn and Tara Henderson to compare children of different races on neuroblastoma risk and survival. And while 75% of white and Hispanic patients survived 5 years after diagnosis, only 67% of Black patients, 63% of Asian patients, and 39% of Native American patients survived to that point. So, patients diagnosed with neuroblastoma are classified as having low risk, intermediate risk, or high risk disease based on the number of clinical and biological factors that we discussed earlier on the slides. Black children in this study had a higher prevalence of high risk disease at 57%, compared to white children at 47%. And Black patients also more frequently displayed individual predictors of high risk disease, such as an older age at diagnosis, stage 4 disease, and unfavorable histology. They're currently doing follow up studies to look for the genetic factors that may be predisposing Black children to high risk forms of neuroblastoma and chemotherapy resistance. And to do so, Cohn's group is going to partner with the University of Chicago pharmacogenetics team to look for gene variations associated with chemotherapy resistance and the development of clinically aggressive high-risk disease in Black and white neuroblastoma patients. As stated by Cohn in the study, their long-term goal is to utilize this kind of information to develop individualized therapy. For example, if they know that a particular patient has a genotype that is associated with resistance to a specific chemotherapeutic agent, they can either modify the dose or treat the patient with a different agent completely. Definitely interesting, to say the least. And here are just some statistics that I was able to pull off of, the web on neuroblastoma. And some of this we may have heard in previous slides, but I'm just going to tie it all in together here. So neuroblastoma is by far the most common type of cancer in infants less than 1 year old. It accounts for about 6% of all cancers in children, and there are about 800 new cases of neuroblastoma each year in the United States. And that number has pretty much remained the same for many years. The average age of children when they're diagnosed is about 1 to 2 years old. In rare cases, the neuroblastoma can be detected by ultrasound even before birth. Nearly 90% of the cases are diagnosed by age 5. And neuroblastoma is very rare in people over the age of 10. In about 2 of 3 cases, the disease has already spread to the lymph nodes or to other parts of the body when it's diagnosed. And I feel as if that alone, that last statistics there, could have a lot to do with why the 5-year outlook is so far when or it drops so far, when you get to that last stage of cancer and you're considered a high risk cancer patient. And here is just all of the references that were used to accumulate information for this project.